Stop the recording. Okay, so one of the very important characteristics, if you will, is when you look at um, the type of glomerulonephritis. The term nephritis means inflammations of the nephron, right? But at the glomerulus, result in either nephritic or nephrotic. And I would say that if it's nephrotic, and I told you that there's proteins in the urine. And you should note also that pathophysiology, that in nephrotic, one will have high lipid, okay, hyperlipidemia. And that's because the liver is trying to make up the lost protein, including the lipid protein. In the case of nephrotic, and that is more red blood cell cast, more red blood cell or blood. And this might be associated with someone that also has edema, if you will. You lose a lot of kidneys not working, sodium might be uptake, maybe associated with hypertension too, um, and edema. Okay, I guess in both cases you can get edema too. All right. Um, so in the book, it talks about how rapidly progressive glomerulonephritis is part of the nephritic syndrome. Okay, and oftentimes what you see there is the art is present. I told you about already, which is the crescent shape, but rapidly progressing glomerulonephritis can cause a number of things, right? It could be related to Wegener. It could be related to glomerular basement membrane or Goodpasture, right? In Goodpasture, we saw that it's basically the antibody autoimmune disease that is binding to the basement membrane in the lungs, for example. Uh, okay, so so this slide will tell you that in rapidly progressing glomerular nephritis, okay, the take-home message is that it is the crescent shape or arc uh, feature that you often see, okay, in histology. And there are three cases or three different pathophysiology mechanisms of these. Either immune complex in glomerulonephritis. So you can see over here glomerulonephritis, okay, um, that is associated with lupus. You see here, and in lupus here is essentially low C3 or C4. So while it's, I mean, I write it down here for you guys uh, to think of in terms of the arrangement. In fact, most likely I'm going to stick with this, but it's not um, strictly black and white. I guess that's what I'm trying to say. It's because this rapidly progressive glomerulonephritis could be related to lupus. It could be related to Goodpasture, right? But this thing is true that if it's related to Goodpasture, there is no anti-neutrophil cytoplasmic antigen, or ANCA is negative, and C3 or C4 level is normal. All right. All right. So you can see the three of them types of rapid progressive glomerulonephritis. The lupus one, the glomerular nephritis associated with vasculitis, like the Wegener, you see here, Wegener, and associated with Goodpasture syndrome. Okay, which is this. So rapidly progressive, I should say that it could be here. It also could be here. Rapidly progressive glomerulonephritis and rapidly progressive glomerulonephritis. Okay. Now it doesn't matter what causes it. Okay. What is it associated with? But in all cases of rapidly progressive glomerulonephritis, you're going to see a crescent or arch in histology. And you can distinguish between these three by C3. If it's C3, C4 is low, it's going to be more rapidly progressing glomerulonephritis associated with lupus. If it's normal, it could be either these two. If it's ANCA is present, is more Wegener associated, which is Wegener. Or if it's good pasture, then it is ANC is negative. It's good pasture. Okay. All right. So that's why this slide is important. Okay. How if it's immune complex glomerulonephritis, lupus nephritis. So again, C3 or C4 would be low in this case. If it's good pasture, then the absence of ANCA. If it's polyangiitis, for example, then it would be vasculitis. The ANCA is present. Okay? But in our case, all of this is part of the nephritic syndrome, which means blood. You will see red blood cells in the urine. Of course, oftentimes people have kidney problems, so a flank pain, edema, and decreases urinary output. You also see that the bun level will be increased, including creatinine. Okay? That's your typical signs of kidney failure. Now here's another interesting one, Alport disease. Alport disease is an autoimmune disease that binds to type 4 antigen, type 4 collagen. In people with Alport syndrome, because type 4 collagen is also finds in the eyes and the ear, they also have abnormality, hearing loss, or vision impair. Okay, so my clinical question will probably be, say, if someone have hearing loss and eye impair, right? What disease that you know that is associated with that? Well, now you know it's Alport syndrome, the type 4 collagen. The thing is that where do you put this? Is this part of nephritic or is that part of the nephrotic syndrome? Well, it turns out that at the young age, it might start out with nephritic, but progressively, as it get older, you can get nephrotic. And so it's no longer just black and white, okay? Exclusively these, right? But in fact, if you want, you can put Alport syndrome could be here, or it could be here, depends on the age. But you know it's Alport because it's type 4 collagen that defective associated with Alport is hearing loss and vision impair. Okay, so nephrotic, we're going to look at nephrotic. So this is the one, a lot of protein. How much protein? About 3.5 grams per day. That's a lot of protein, right? So again, clinical question will be, say, protein plus. That suggests that you have nephrotic. I'm not going to give you a number that you can compare with. Because you have a lot of protein loss, the albumin in the blood is low, so we call that hypoalbuminemia. So decrease in colloosmotic pressure, therefore edema. We saw that will because you don't have any colloosmotic pressure, you're going to have fluid accumulation. So this would probably be the transudate type, not the exudate. Blockage of the lymph node could lead to edema, but that's known as exudate. Exudate, this will be transudate. And because of protein loss, um, you want kidneys not able to get rid of the sodium. Sodium is retained, might have hypertension, but very characteristic with nephrotic is that heavy lipid in the protein. So we call that hyperlipidemia. Uh, An example of this would be minimum changes, diabetic, amyloidosis. All these is secondary. Okay, secondary. Um, I mean, these is the primary disease. Secondary is nephrotic, if you will. So minimum changes disease is the most common one, if you will. Membrane glomerulopathy and membrane proliferative glomerulonephritis. Again, if you go back here, and you can see that um, here's nephrotic. The most common one is minimum changes, hence there's one. Okay. Um, the second most common is membrane glomerulopathy, um, and then if you can think of it, the in adult, okay. So the minimum changes you can see both in children and adult. Okay. In nephrotic, it's also typically is secondary to other diseases. This is the primary disease: diabetes, amyloidosis, systemic lupus erythematosus. So when they have this disease first, the secondary is nephrotic. Okay. So here's what minimum changes. This is the most common, if you will, and it's due to the loss of podocyte. What are podocyte? Podocyte are essentially forms as the visceral layers of the Bowman's capsule, if you will. Okay, so you lose those cells is what typically, and then it's recover. So minimum changes, like the name implies, that you might have a kidney problem uh, acutely, and then it goes away. Okay, very common nephrotic syndrome. All right, so in membrane glomerulopathy, or also known as membrane nephropathy, is the second most common of nephrotic. Okay. But only in a third of it in the patients have it. So if people have, of all the people have nephrotic syndrome, right? And you say, okay, let's say there's 100 of them, you suspecting having nephrotic syndrome, and you say, oh, it's membrane glomerulopathy. That's your guess, right? Then I'll say, well, you will be right in 33 times. And it's only a third of them that's common. The other 2/3 is probably going to be like minimum changes or secondary disease due to diabetes. Okay, remember, so that in the U.S., I told you that when someone show occult protein, right, your first thing to think of is diabetic related. Okay. Um, okay. So this membrane glomerulopathy is basically the membrane get thickened, and it's due to immune complex. Okay, and I mean, other things associated solid tumor and thrombosis. Let's There are other causes, but I don't want to complicate things. Just say it's immune complex associated. But how do you know that um, the this is related to membrane glomerulopathy? Okay, is because of the special staining that you can do. Okay, um, and essentially, in the case of membrane neuropathy, there are other causes like drugs, infections, immune disease. Um, right, that's not important. But what is important? So here is in fact what is that there's an expansion of this. These cells right here, these are all podiocyte. The green one is podiocyte. Okay? Now this podiocyte get enlarged. You can see that. It could be due to directly antibody binds to that. It could be due to the immune complex bind to that. Right? So that's the common theme is that you can have either the antibody that binds to the basement membrane or the antibody antigen complex that get large in this membrane. But you can rule out this disease versus the other because of the enlargement of these podiocytes. Okay, and there's a special staining. Um, the silver staining will shows you you have these bumps. Okay, so then that's my clue. So it has the irregular spikes protruding from the glomerular basement membrane. Uh, and that's the special staining help to distinguish whether this is membrane uh, nephropathy or minimum changes. Well, minimum changes you won't see anything. Uh, all right, now focal segmental glomerular sclerosis, meaning that focal mean local, not everywhere, but in some places. You can see here. Here it took place in this one um, glomerulus. Raquel, you have a question?
Yes, Professor. I saw where you mentioned that the membranous glomerulopathy is the second most common cause of the nephrotic syndrome, but then another statement says it's the second most common cause of it in adults. So it's it's the first, more common cause in
Yeah.
kids.
Okay. Okay. Now, in when we're talking about nephrotic syndrome, okay, nephrotic syndrome can be seen in children, and it can be seen in adults. Okay, so that's basically in the minimum changes, the most common okay type of nephrotic. Okay, however, in membrane proliferative glomerulonephritis or neuropathy, uh, you will see it in adult, right? You don't see it in children, so it is very common in the case of adult nephrotic syndrome. Right? That makes sense because it's not the number one of nephrotic. It's number one within the adult. Right? But you see that a lot in adult. But in adult, you can also possibly see um, diabetes that is associated with nephrotic. So in other words, uh, nephrotic is secondary to other diseases like nephrotic lupus or even amyloidosis. Does that kind of make sense?
Yes, I get it now.
Okay, yeah. So it is number one in adult. Okay, it's number adult. Okay. Again, I'm just going to turn this off. Okay. Um, yeah. So I would think that the uh, four um, diseases or associated with glomerulonephritis that is considered nephrotics are the minimum changes. You saw that. Um, membranous glomerulopathy, uh, secondary to other disease, and focal segmental. Okay, so those are the four that you should generally think of when you think of nephrotic syndrome. So that's easy. Okay, that's 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 been we'll finish with this column, if you will. All right. Now, the nephrotic syndrome. Why am I jumping around? Okay. One of the important thing with nephrotic syndrome is that because there's a lot of proteins, you can actually see these histologically proteins in these. Right? And it takes a trained eye, but you can tell between proximal convoluted tubule and distal convoluted tubule. This, for example, is proximal convoluted tubule because they're a broad border. Okay, so what I mean by that is that if you look at the lumen of a proximal convoluted tubule, you will see that they have brush border. Okay. So basically, it is a microvilli to increases the surface area for absorption in PCT. Okay. In the distal convoluted tubule, it's the lumen is bigger, but you do not see any brush border. Okay, so this will be considered as distal convoluted tubule. This is more proximal. Okay, um, and so forth. It But the idea is that because protein has eosinophilic staining, so you will see it in the lumen. Okay, you will see in the lumen of the uh, collecting of the tubule, renal tubule. Okay. Membrane proliferative, remember that's due to um, any number of a thing, but the important thing is that if you do a special staining, you will see this spike. Okay, so that's my clues to you, is that you will see a spike. All right, so now we're going to talk about nephrotic syndrome. And again, the difference between nephrotic is that nephrotic has a lot of protein. Nephritic, you see a lot of red blood cell. Okay, so most likely look for clue, red blood cell, plus, plus, plus. Think of it as nephritic. Now, um, nephritic, very similar thing. Hypertension and edema that we see nephrotic, but you do not see heavy lipid here, right? And you do not see hypoalbumin albuminemia here either. So the albumin level is normal, and the not a lot of lipid protein like you would with nephrotic. There are different kinds, as you can see here. Easy to think of, again, you guys, is to within the nephritic, there's two groups, right? So think of it as if it's look at the post-infection. Let's think of it as antibody-mediated. It's going to fixed complement C3 and C4 is going to be very low. So that's you think of that as post-strep or acute glomerulonephritis, right? That's acute one. Um, Now, if it's normal, then you have to think of whether it is ANCA present or absent. If it's ANCA is present, then it's more of the disorder related to the blood vessel, Wegener or polyangiitis, right? If it's not, then think of it as good pasture. And good pasture links to that to rapid progressive glomerular nephritis, also known as crescent. Okay. All right. So yeah. So basically, this is the same thing. Shows you that the problem with glomerular disease is that it could be due to antibody that binds to the basement membrane or the antigen antibody complex. Okay. And you can have an expansion of the podiocyte, okay, which is of these cells, which we saw in membrane proliferative, right? Or it could be due to expansion of this enlargement of these cells, which in the case of rapidly progressing. Okay. All right. Acute diffuse proliferative glomerular nephritis, or the acute. The acute is the same thing as post-TERP. Okay. Nephritic, we saw. Don't worry about whether it's group A, hemolytic streptococcus, but is fixed complement, okay, fixed complement to attract its polymorphoid nucleus. So in this post-strep, two additional factor that you see is that C3 or C4 would be low because it's complement fixed, but you can also see the presence of a neutrophil, polymorpho nucleus cell, into this area. Okay, so histologically, you would see that, or scanning electron micrograph, you would see that this. Okay, so this is a cartoon drawing of the glomerular nephritis. Sorry, of the glomerular, you have the uh, endothelial layers of the blood vessel. The basement membrane here is blue, and the podiocyte, which are green. Okay? And in this case, you get this glomerular expansion. But you also see these right here, which is neutrophil, neutrophil, neutrophil. So this is the electron micrograph. Um, um, 20,000 maybe magnification. No, not even that. Maybe 10,000 magnification. Okay. So in this post-strep or acute diffuse, similar thing. C3 or C4 will be low. Okay. Now we saw rapidly progressive glomerulonephritis could be linked to three things. It could be to post-strep. Okay. If it's post-strep, then you think of C3 or C4 is low. And if it's ANC negative, then it's most likely it's going to be the Goodpasture syndrome, right? Here, type 1, Goodpasture syndrome. And if it's ANCA is present, is more Wegener, okay, with this type right here. But in all three cases, what you see, this expansions of that endothelial there, okay, and how it looks like a crescent shape. Right? That's the rapidly progressive glomerulonephritis. Sometimes what they'll often do is you can actually do the antibody of the tissue, and this antibody you label fluorescent, okay, chlorochrome, so that if you shines the UV light, it's going to light up. Okay, so here just type 1 Goodpasture, but you can see that if you use the antibody to the basement membrane, you light it up, and you can see how this is all of this is lighting up. So this is all shows you the expansions of that endothelium. So this is used a special antibody that is labeled with fluorochrome. Again, Goodpasture is very similar to type 4 collagen, but it's different type. This is different from Alport. So Alport, also type 4, but that's associated with hearing and vision impair. Okay. That's Alport. And Alport could be either nephritic or nephrotic. Okay. And you can see as part of nephritic, you see it's hematuria. As you can see, red blood cell cast. Similarly, a type 1 Goodpasture, just that proliferating the crescent shape. Okay. All right. Membrane proliferative glomerular nephritis. It is present both nephritic and nephrotic. I mentioned already, if it's associated with Hep C, then it is C3 or C4 is low. and it might be associated with cryoglobulinemia, meaning that there's proteins that it's getting, uh, uh, proteins that is related to temperature. Okay. In the case of membrane proliferative glomerulonephritis, there are two types. This is the thickening of the capillary wall. Oftentimes, they will describe this as bumpy. Okay? Um, see how you can see these look like bumpy? Okay. All right. Okay. So that's sort of like give you a brief description and yet extensive in terms of harder to distinguish because you don't know familiar with some of that term. But if you start with that table and memorize it, that will give you a good basis in understanding different types of glomerular disease if it's associated with nephritic or nephrotic. And also stress that nephrotic, lots of protein in the urine and heavy lipid in the blood, okay, but low albumin. Whereas, so that's nephrotic. Nephritic is more blood, uh, more blood in the urine. Okay. All right. So is it okay if we just continue and then we'll end it early um, instead of having a break? You guys have any preference?
Sure.
Okay. All right. So acute renal failure. Uh, acute renal failure, meaning that all of a sudden this person does not have any urine output, and then the buns started slowly to increase. And we can think of the acute renal failure in three different ways. One is pre-renal. Okay? Pre-renal refers to perhaps there is less blood flow to the kidney, and thus acute tubular necrosis will be often seen. Okay, it could be due to within the renal themselves, right? And then this uh, in the in the kidney itself could be due to that glomerulonephritis that you saw, right? It's very common, uh, or in vasculitis, um, or it could be due to a nephrotoxin, the kidney filtered toxic compound, and the toxic compound is damaging the renal tubule, if you will. And in some cases, you can have the interstitial defect, like a fibrous or accumulations in the liver, or even some of the autoimmune disease that is accumulating in the interstitium. So, three potential causes of the acute renal failure: pre-renal, intrarenal, and post-renal. What is post-renal that might cause that? Well, urinary tract obstruction, if you will, that ultimately leads to hydronephrosis, right? And so now you should think of hydronephrosis caused by obstruction, or it could be caused by non-obstruction in some of congenital disease. Okay, um, and congenital you often see in children more than adults. Okay, so in renal vasculature, which is basically the remember I told you that in the case of nephrotic uh, uh, syndrome, the proteins in the urine, uh, we, the you can say the third common cause. Why don't we just say that? The third common cause is often associated with a, a secondary to other diseases, um, like diabetes, like lupus, or amyloidosis. Okay? And so the secondary glomerular disease, they call this, is known as the diabetic glomerulosclerosis. It's not uncommon that diabetic have many consequences that can get uh, the retinal problem, blindness. You can get blood vessel problem that leads to amputation, and you can also have uh, a kidneys problem, as you can see here. Okay. Uh, Other causes of secondary glomerular disease is renal ablation, glomerulopathy. That means you slowly losing the renal function over time. Uh, this other causes of renal failure is usually considered as disease of renal vasculature. Okay. Benign versus malignant nephrosclerosis and renal vascular hypertension. Benign, meaning that usually it is not as much liver, not as much of the nephrons of scarring as case of malignant. And malignant nephrosclerosis is usually due to uh, renal hypertension. Renal hypertension, and it's a characteristic of renal hypertension. Is very similar to um, uh, pulmonary hypertension. Do you guys remember in pulmonary hypertension, what does the blood vessel, um, like the pulmonary vein, pulmonary artery, for example, will look like? Pulmonary artery more than pulmonary vein. In pulmonary hypertension, what do you expect to see? Joseph? Joseph?
Pulmonary arteries kind of dilate or constrict.
Well, they're dilate, but how would you, unless you have a scope that you go in there and you see it's dilating, but chronically, histologically, I suppose, what do you expect to see histologically?
The thickening of the walls.
Huh? Yeah, the thickening of the blood vessel, like the onion skin, kind of, right? So in malignant nephrosclerosis, due to hyper um, renal hypertension, you will see exactly that. Okay. All right. So okay. So here is the difference between normal kidney and this is benign nephrosclerosis, often associated with hypertension and could lead to malignant. And here is where malignant nephrosclerosis that you often see, how you can see that there's a characteristic of thickening of the smooth muscle wall. And that's a very characteristic in the arterial of the like the afferents arteriole in the kidney, if you will. Okay. All right, so that's all I'm going to talk about the renal vasculature and secondary glomerular disease due to diabetes, which is now you to think of as the third causes of nephrotic syndrome. Okay. Acute tubular injury leads to muddy brown cast. Remember that? That's suggested that it's acute tubular injury. An acute tubular injury could be due to here. Okay, so you think of the muddy brown cast or tubular cell cast. Okay, that's usually two defining feature, okay, of the tubular injury. And tubular injury could be due to ischemic because the cells of the renal at the proximal convoluted tubule require oxygen. Okay, in a number of cases, we consider as pre-renal that could lead to ischemia, like septic shock, massive hemorrhage, dehydration, severe burn, right? Losing a lot of fluid. So pre-renal, if you will, not a lot of bloods going to this area that leads to tubular injury. That's one, okay, group. The other group is nephrotoxin. The nephrotoxin example will be contrasting dye is very common, but other poison because the kidney is removing this, and your renal tubule cell is now encounter these. Um, okay, so essentially what you see here is that um, the the um, the injury of the renal tubule causes the defacement of the cells of the renal tubule. And when they come off, all these cells that are essentially not supposed to see in urine can form casts, but in the process, it actually can block the urine flow, if you will. And so the pyramid will look congested. You can see here. Okay. This area here, the cortex look wider than the other, so that means not a lot of blood supply that goes into here. Acute tubular nucleus can further nephrotoxin. Okay, so essentially toxin slough off of necrotic cells and tubular obstruction. You can see that. That's the key. This is the pathophysiology, how nephrotoxin can lead to acute tubular necrosis and might lead to these enlargement, congested, okay, pyramid. Okay. All right. And here's a cartoon showing how defacement, if you will, of these tubular cells, and the tubular cell can actually lead to this um, the uh, the muddy brown cast, essentially in the urine, but in the process, you might see this uh, coagulation, no, group of protein cells, group of cells here that leads to obstruction. Okay. Here, this is a distal convoluted tubule because you can see the lumen very well. And this most likely it's affected the proximal convoluted tubule. Okay, more. And you can detect them as brush border. Here's your glomerulus. Glomerulus look nice. You don't see that crescency as in rapid progressive glomerulonephritis. Here shows you furthermore, here, D here tells you nice lumen, that's a distal convoluted tubule. Distal convoluted tubule. Here's your proximal convoluted tubule. Okay. And how there's a lot of protein occurs in the proximal convoluted tubule. All right. Interstitial disease. Interstitial disease considers is an example of this. Interstitial nephritis is part of the tubular interstitial nephritis. And when they say it's pyelonephritis, the word pyelo refers to the pelvis. Okay, so most of the acute pyelonephritis is caused by the infections of E. coli ascending. Okay, so with the urinary tract infection, very typical is the common bacteria is usually E. coli. It just can be treated with antibiotic. Okay, and it shows you here is that the due to the ascending bacteria of the urinary tract. Now, what happened is that is these people who have diabetes often have a lot of these pyelonephritis is because they produce a lot of glucose in the urine, right? And, just like children love, glucose, bacteria will love glucose as well, right? And, and then when you have all that urine with glucose, that's created a good, rich source for bacteria to grow, and they could actually causes pyelonephritis. Now, if it's pyelonephritis that is when we talk about pyelo, we really refers to this, the pelvis, right here. Okay, and a lot of these is due to the ascending, like E. coli, but you can get nephritis more like a cortex out here. Okay, you see that, and that's usually is spread not through the ascending here, but rather due to the homogeneous spread is to the blood. And there is not might be E. coli, but it could be due to staphylococcus, okay, or fungal aspergillus in the case of immunocompromised. So that's key different, if you will, is pyelonephritis can caused by either the ascending bacteria of the urinary tract, in which case it will be E. coli. But if it's more of the cortex, then it's due to the blood spread, homogeneous spread, and there it's not necessarily E. coli. It's typically Staphylococcus. Pyelonephritis, urinary tract, all that means you get a lot of immune cells here. You might get pus. This is usually abscess out here, so that's usually meaning that a lot of neutrophils involved, homogeneous spread in this case, for example. Like any fever, chills, onset, flank pain, malaise, increased numbers of white blood cells called leukocytosis, particularly neutrophil. Okay? So this pyelonephritis is easily treatable with antibiotics. Chronic pyelonephritis is usually due to more persistent bacteria infection, which is basically given an antibiotic, they go away, they come back, and so forth. Okay, that's usually called chronic. And the consequence of chronic pyelonephritis oftentimes is it can actually, a lot of immune inflammation can lead to the scarring, particularly the major calyx and minor calyx, right? Which it get really distended. You can see that. All right. Okay, so then the last thing that we're going to talk about is cancer. Now, there are two types of renal tumor, the adenoma and the carcinoma. Adenoma is very glandular. Carcinoma is epithelium, we can see that. In the case of benign tumors, there are papillary renal adenoma and oncocytoma. These the glandular type papillary, okay, it's really very benign. The oncocytoma is also very benign, but you can actually tell them the oncocytoma because these cells have a lot of mitochondria. They have a lot of eosinophilic staining, if you will. Um, um, the oncocytoma is very common benign solid tumor. And now in children, there is a benign tumor called the Wilt tumor. I'm going to show you a little bit in the Wilt tumor and how sort of like that, the tumors derive from the cells, sort of like the stem cells that involve in maybe um, the kidney, if you will, or the nephron. Thus, if it's stem cell that potentially can produce other tissue like hairs, cartilage, and so forth. Um, that's a benign. Well, no, sorry, that's a tumors in children. Okay, it can be very malignant tumor, known as the Wilt tumor, and in the other types of malignant tumors are renal cells carcinoma. And the renal cells carcinoma, you can see it's involved in paraneoplastic syndrome because this is known as a great mimicker because it can produce this hormone that you're going to see. Transitional epithelial are typically cells that is lining the urinary tract, like from the ureter to urinary bladder to urethra. Those cells there can develop transitional tumors, if you will. All right, so the typical adenoma glandulars of the tumors will look like this. Just glandular, benign. They grow really big. The other ones is known as the oncocytoma, right? And oncocytoma is very characteristic in that is you have a lot of mitochondria, okay? That's the key in these cells. In the malignant type of tumors that you often see in children, okay, it started out as benign, but it become malignant, and it usually finds in one cells that these tissues derive from this metanephritic blastema, which really means it's stem cell, if you will, and as such, they can actually produces these muscle, cartilage, and bones. Okay? So here's where the Wilt tumor might look like. It start out might be a neoplasm, and it could become aggressive malignant tumor. Okay, and the Wilt tumor is very, very common in children. Okay, so keep that in mind. It's children. Okay? Children. Renal cells carcinoma, on the other hand, typically more adult. So in renal cells peak around 60-year-old, okay? And more often in male than female. And this is due, again, translocations of chromosome, just like, remember, the chronic myelogenous leukemia, CML, translocation between 9 and 22 chromosomes. So that translocation is very common in a lot of tumors. Okay. All right. Now, the renal cells carcinoma is known as the great mimicker because they produce PTH, they produce EPO, and they produce this renin. Okay. So typical, you should know that the kidney produces EPO, right? And the kidney produces renin. So it's not surprising that these cells do put out EPO and renin. Okay? What is surprisingly is that these cells produces PTH as well. Okay? So it is related to that paraneoplastic syndrome. Okay? Yeah. Like remember the oak cells, small cells, carcinomas, and the lung, how that can put out ACTH, for example. All right. Renal cells carcinoma, when a person who, I guess you could say pee blood, in the urine you see blood, that is certainly is suspected of tumors in the kidneys. The second thing that you should think of is blood nephritic syndrome, right? So then you got to go into history. This guy's had an infection before. You got to look for an antibody, whether HANC is there or not. And you have to look for a complement protein. Is it high or low, okay, and so forth. In renal cell carcinoma, typically a lot of malignant cell that do migrate to other distant organ, the bones, the lungs, typically metastasize to. If it's metastasized to that, in that case, it's 5-year survival, you know, very low, 30%. If it's not, you catch it early, 90% survival. That's pretty good. And typically, it doesn't have to be occurs bilateral. If it's on one side, you can definitely remove it because one can live with one kidney. Okay? So it's not uncommon that people donate a kidney because you only need one kidney. You don't need the other kidney. Now, lastly, transitional cells carcinoma, not as frequent as renal cells carcinoma, cancer-wise. And these transitional cells carcinoma can see everywhere, particularly in the urinary bladder, right? Whereas Wilt tumor and renal cells carcinoma only finds within the kidney. Renal cells carcinoma, a great mimicker, seen in adult, usually in their 60s, whereas in Wilt tumor, typically sees in children. Okay? Now here, this is this last slide shows you how the renal cell carcinoma can occur anywhere that has transitional epithelial cell starting from the pelvis, right? The distal portions of the ureter, the ureter themselves, urinary bladder. Okay. All right. Okay, so that's just the conclusion of the renal pathology. There's certainly a lot of disease, and I understand that it could be confusion with the different name of glomerular disease. But I would say that try to study really hard, look at that figure where I break down for you different disease from that table or chart of glomerulonephritis. Okay? So if you understand that, that's like 50% of the battle already. The other thing is just fill in the blank to know a little more details about those diseases. Okay, I'm going to stop here. Are there any questions?
I thought we were gonna do a little review. Are you gonna post something? I thought you said you were gonna do a little review, but I know you sound tired. I don't know.
Do I do a review? I don't think you guys need a review. You guys gonna do it. It's fine. Okay. I'll try to help out my 302 student with the review, but come on. 17 questions on endocrine system, 7 on kidney, and 17 on the kidney pathology, 17 on endocrine, and 17 on the respiratory. You can do it. Alrighty, I still have a lot of things I have to do. I have to grade your PowerPoint. I have to grade. Please try to submit the extra credit, and I gotta grade your quiz 6, and you do get to drop one quiz grade. Okay. Any other question? Stop the recording.